I will show you that infectious diarrhea are indeed well documented. There is little doubt that there is a work that they are effective. And respiratory infections are or have also a acceptable documentation now that there is a modest effect. Urinary tract infections, I'm not aware of clinically of well-conducted studies that would support that context. I haven't come across anything. Irritable bowel colic, I think we heard from Flavia already, and there are nice studies also showing that colic in themselves are actually reduced. And then, of course, the necrotizing enterocolitis, which we already heard and which I won't go into discussion. And then, of course, the allergies, which I will come back to. So against diarrhea, I will make my task rather easy by actually summarizing and giving the references to two, and there are actually another two or three, even three meta-analyses now comprising well over 30 controlled studies, clearly showing more or less the same thing, that the strains that have been the Lactobacillus, Acidophilus, Reuteri, and Rhamnosus, and they are working in a rather similar way, the efficacy, they do shorten the duration of an infantile gastroenteritis, whether it be rotavirus or unknown origin, with something around 1 day or slightly less than 1 day as an average. There is also antibiotic-associated diarrhea, which we will hear as a special talk shortly after me, but I will only show you one study which as a sort of tidbit for the final presentation, that there is actually now clear data showing that you can prevent the induction of diarrhea induced by treatment with broad-spectrum antibiotics. And that is one of the also rather few indications which are also shown in adults. Now a few words about the Weizmann study. Some of you may have heard the follow-up that this effect was not lasting, so when they stopped the treatment, the efficacy, the protection was gone. So they looked on the number of fever days, episodes, diarrhea days, and diarrhea episodes in daycare centers, and there were in three groups, and they compared two Lactobacillus strains showing that they were all efficacious, although there was actually a significant effect also between the two probiotic strains. And as I said, there are also other studies giving support with other probiotics giving support for this kind of notion. The infantile colics is comparing the standard Millicon treatment. This is clearly, obviously, not a blinded study, so I think we have to go to Flavia's studies to really get the confirmation. But this was also a study showing an effect by probiotics in reducing crying time. Now then, coming into this discussion on bacteria and the gut flora. Actually, this started more than 15 years ago when we showed differences in between two countries like Estonia and Sweden with a low and a high prevalence of allergies. And then it has been shown by several other groups around the world that there are differences in the gut microbiota between those who are allergic and those who are not. The point I'm making is there are differences, and we could discuss what are the differences because they certainly vary among studies. But this is actually something with bifidobacteria that we did prospectively at all ages, and these were actually taken stool samples at 5 days, 1 month, 3 months, 6 months, and 12 months, and then looking on allergy as an outcome, atopic dermatitis as an outcome by age 2 years. So this is a prospective study, and what you can see here is that virtually all the children, infants who remained healthy and did not develop allergy, we could isolate bifidobacteria either at 5 days or 1 month or at 3 months, as compared to only half of those who developed allergic disease. We followed this up and looking on the relative composition of bifidobacteria at age 5 between those who are and those who are not allergic, and the counterpart of this is the difference between Clostridia. And there is an inverse relationship between lactic acid flora and Clostridium, notably Clostridium difficile in many studies. So then looking on treatment, there have been studies. Again, there are studies that are positive, there are studies that are negative, and there are studies that don't see anything at all, either good or. But so I've chosen here to show you one of those because it's typical among the positive, and that is a Danish study that they compared. Also, they had probiotics with rhamnosus and reuteri, and what you can see here is a typical. There is a modest, it's a rather small effect, and none of these studies have shown any strong or convincing or really enthusiastic driving effects. But they have a trend that there is a modest effect. We've looked at this prospectively, and again, giving lactobacilli starting 4 weeks before birth to make sure that they were properly colonized. And as you already heard from Teresa, the maternal vaginal flora is the first exposure to microbes, so we wanted to make sure that the mothers were colonized by the time we got started, and then giving it to the baby through the first 12 months of life for the first. And the outcomes were allergic disease, skin prick test, and IgE, allergen-specific IgE. And what you can see here is that there was a trend, a trend for less IgE-associated eczema on the second year of life. Otherwise, there was not any dramatic effects. But the really interesting thing is that these children, they all had a positive family history of allergy. But 75% of them had a maternal heredity, and 25% of them only had an allergic father or an allergic sibling. Had we limited the study to look on those who had a maternal heredity, who had an allergic mother, then we would have had stronger effects of the treatment. Now, we didn't publish it that way for a reason, because the intention, because this is a sub-analysis or post-hoc analysis. But with regard to what has come out later, it's interesting that those who had a maternal allergy actually were those who had the effect of the giving the probiotic 1 month before birth and then through the first year of life was more pronounced. So why do the studies don't show the same thing, and why do we have some who are positive and some who are not? Of course, there is the sort of thing that you always have, which is the strain variation, and which of course is a question that we may discuss. Is it the strains by themselves? But is it also the environment? Is it that in one environment where you have a microbial ecology, that these bacteria may be more important to add to it or less important to have it? So it's quite reasonable from an ecological point of view that you would not have the same efficacy in any environment, because it would be different in what is the typical environment, the microbial ecology in a given environment. And then, of course, you have the host, of which we know very little about what it is. So the consequences so far, is I would say that the facts are that microbiota are established very early in life and essential to health, and we heard that already. That the neocolonization may have long-time consequences. I'm not prepared to say lifelong, but they certainly has a long-time consequences at the time when the immune system is evolving. That probiotics do have documented effects, particularly encouraging in children. That they are safe, because, and as we already touched on those issues, the fiction is that not all live bacteria are probiotic, which we heard, because, and certainly not anything that you would find on the shelves. So discussion is limited to these 5-6 strains we are talking about so far. And that the future, I'm suggesting you as a mind-boggler, is that we may have an effect, and hear much more about, as we are learning about these immunologically mediated diseases of affluence, such as allergy, inflammatory bowel disease, autoimmunity, and very, very recently as well, obesity, as we've heard in these days. So the future treatment on the so-called hygiene hypothesis, what we are talking about is that it may be that we need a wider microbial effect. And with that, I thank you for this.